Mage-D2 and the regulation of renal cell transporters. Definition: Mage-D2 encodes melanoma-associated antigen D2 and maps to the X chromosome. We also identified two different Mage-D2 mutations in two families with idiopathic polyhedrons.
Disorders of sodium are actually disorders of water. That is to say, sodium is a reflection of the tonicity of the blood. So if you don't have enough stuff in the blood, or you have too much water, you'll be hypotonic and hyponatremic. Conversely, if you have too much stuff or not enough water, you're going to have hypernatremia. Let's see if we can put this into perspective by revisiting the basic sciences and going over how our body is arranged. Our body is set up something like this. The blood and the cells are separated by a semi-permeable membrane with the same amount of stuff on either side and same amount of water. All this white space, water. These circles is the stuff. We live isotonic. That is, the stuff in the blood is the same as the stuff in the cells, and the tonicity is the same. And it's that way because of the semi-permeable membrane. Now, if you had too much stuff, hypernatremia, there's more stuff in the blood than there is in the cells. And water is going to go to an area of higher concentration. So water is going to leave the cells across that semi-permeable membrane and into the blood. The impact that this has is that the cells are going to shrink. This balances out the water, but cell shrinkage is no good. That's going to provoke some symptoms. Conversely, on the other hand, if you had hyponatremia, you had too little stuff in the blood. Now there's more water in the blood than in the cells, and because of the semi-permeable membrane, the water is going to go into the cells. Too much water in cells leads to swelling. Swelling of cells is bad, shrinkage of cells is bad. They both lead to symptoms. But the symptoms the person is going to feel, or that you're going to notice in a patient, is going to be dependent on calculus. What I mean by that is it's all about the delta. It's the change of sodium over the change in time. That is, how severe the sodium change is relative to how fast that change occurs that is going to cause how bad the symptoms are going to be. So if your sodium shift is big and the amount of time it takes to get there is fast, the body is not going to have time to adjust and the symptoms are going to be worse. If the sodium shift is small and it takes a long time to get there, then the body has a chance to adjust and the symptoms may be not present at all.
Applications in medicine. Baller syndrome is a rare genetically heterogeneous disorder characterized by renal cell wasting, hypokalemia, metabolic alkalosis, and secondary hyperaldosteronism with normal to low blood pressure. There are two distinct presentations of the syndrome. First one is antenatal Baller syndrome, and the second one is classical Baller syndrome. Both forms are inherited as autosomal recessive traits.
Production of renal prostaglandins is often found. Magnesium wasting may also occur. Diagnosis: people suffering from Bartter syndrome present symptoms that are identical to those of patients who are on loop diuretics like furosemide. The clinical findings characteristic of Bartter syndrome are hypokalemia, metabolic alkalosis, and normal to low blood pressure. These findings may also be caused by chronic vomiting. These patients will have low urine chloride levels. Abuse of diuretic medications. The physician must screen urine for multiple diuretics before diagnosis is made. Magnesium deficiency and calcium deficiency. These patients will also have low serum and urine magnesium and calcium. Patients with Bartter syndrome may also have elevated renin and aldosterone levels. Prenatal Bartter syndrome can be associated with polyhydramnios. Pathophysiology: Bartter syndrome is caused by mutations of genes encoding proteins that transport ions across renal cells in the thick ascending limb of the nephron. Bartter and Gitelman syndromes can be divided into different subtypes based on the genes involved. Treatment. While patients should be encouraged to include liberal amounts of sodium and potassium in their diet.
Pros and cons. Pros. The initial presentation was more severe than in known types of antenatal bladder syndrome, as reflected by an early onset of polyhedrons and labor. All symptoms disappear during follow-up in the infants who survive. Cons. Patients with antenatal bladder syndromes may carry loss of function mutations in the genes encoding the furosemide-sensitive sodium-potassium chloride cotransporters NKCC2. In most persons with antenatal bladder syndrome, compromised function of the thin ascending leaf of the lobe of Henle manifests in utero and is characterized by massive saturated polyuria. Postnatally, surviving patients with antenatal bladder syndrome have persistent salt wasting, hypokalemic metabolic alkalosis, hypercalciuria, and a tendency toward nephrocalcinosis.
So let's kind of get your bearings. This is the lumen of the ascending loop. So this would be the apical membrane. And then the basolateral membrane would be here. And you have your interstitial fluid in your blood off to the side of that. So once again, you've got your sodium-potassium pump. So that's the first one that we've always been talking about. So we know we have a low concentration of sodium inside the cell, and we have a high concentration of potassium inside the cell as well. So knowing that then, that tells us that sodium must be at a high concentration in the lumen. What this diagram is showing is the fact that you can transport potassium using this little transporter here, and potassium would go from a low concentration in the lumen to a high concentration in the cytoplasm of the cell. So this is going to be sodium, potassium cotransport. So it's a type of secondary active transport. Now, sodium can also be transported via chloride ions. So chloride ions would be going from a low concentration toward a high concentration. So that means that you can have sodium chloride cotransport as well. So sodium can be cotransported with chloride, or sodium can be cotransported with potassium.
Applications in medicine. In Ecuador, there is not too much genetic studies, but doctors and scientists state that 3 pregnancies with male offspring in one family were complicated by severe polyhedrons and prematurity. 1 fetus died. The other 2 had transient massive cell wasting and polyuria.
Hello, YouTube. Hi. YouTube user Chris recently asked us to do a video about electrolyte imbalances, so I decided today I was going to do a video about hyponatremia because it's my own personal favourite electrolyte imbalance. I appreciate that having my own favourite electrolyte imbalance is super lame, but I also have my own YouTube channel where I talk about medicine, so I think the boat's pretty much sailed on that one. So, hyponatremia. It literally means too little sodium in the bloodstream. As an F1, I'd see this one all the time, and I'd never really know what to do about it. Do I give more fluids, less fluids, ready salted crisps? It's actually straightforward enough provided you've got the right information and ask yourself the right questions. Remember, in mild cases, hyponatremia can be asymptomatic, but in extremis, it can cause headaches, nausea, seizures, and even a coma, so it's definitely something that we need to sort out. Treatment does largely come down to either giving more fluids or less fluids, but it depends on what the cause is and what the patient's fluid status is, so it does require a little bit of thought. It's all quite simple. You just need 5 pieces of information, 5 simple, non-invasive little chunklets. That's all it takes. Plasma sodium, which you already have, plasma osmolality, urine sodium, urine osmolality, and a decent assessment of their fluid status. Basically, are they wet or are they dry? Anyway, we'll put a pin in those for the time being, because before you can understand hyponatremia, you need to understand what the kidneys do to sodium. Here comes the science bit.
Deep in the human kidney, in the deepest depths of the distal convoluted tubule.
Quick renal refresher. Remember, aldosterone acts on the DCT and ADH on the collecting duct. But for today, let's picture them both snuggled up next to each other so we can get an idea of how they work. Aldosterone acts on the sodium-potassium cotransporter in the distal convoluted tubule. This cotransporter reabsorbs sodium back into the bloodstream from the urine and secretes potassium into the tubule. In doing so, it raises the concentration of solute in the blood compared to the urine, creating a concentration gradient that pulls water back into the blood via osmosis. Put simply, water follows sodium, so aldosterone increases both blood sodium and blood volume. For today's video, we can pretty much just ignore potassium. Sorry, potassium. Now,
Conclusion. Mage-D2 mutation cause X-linked polytrypsias with prematurity and a severe batration from an antenatal bladder syndrome. Mage-D2 is essential for fetal renal reabsorption, amniotic fluid, homeostasis, and the maintenance of pregnancy.
What we're going to do first is talk about the proximal convoluted tubule, since that's the first place that the filtrate enters when it leaves the glomerulus. Keep in mind what we're going to do. We're talking about tubular reabsorption. So what that means is that at the glomerulus, if you look at the picture here, you've got the glomerulus here. We're going to filter stuff at the glomerulus. When we filter it, it ends up in the renal tubule, and we want to reabsorb it. So we want to put it back into the blood. So that's the whole point of doing this. And the colors here are coordinated on your diagram. So the yellow part refers to the lumen, and this is the lumen of the proximal convoluted tubule. Here are your epithelial cells of the proximal convoluted tubule. Peritubular space is the interstitial fluid, and then of course you have the plasma, which is typically your peritubular capillary. So when we're reabsorbing, we want to take our solutes and our water and our sugar into the plasma from the nephron, specifically the lumen of the proximal convoluted tubule, and into the plasma. Keep in mind that our nephrons do most reabsorption, or most of the reabsorption occurs in the proximal convoluted tubule. And this is going to involve what's called transepithelial transport. So we're going to be transporting stuff across the epithelial cells. And what we're going to reabsorb is listed here for you. So 99% water, all of your sugar, almost all of your salts. And to give you some more details, you can look at this table here on the right.
Thank you.